Hello, this is my video on the QA program. So for all the future videos, I'm probably just going to refer to the instruction by its nomenclature. For me, that helps reinforce what is the actual name. So like when it comes up on the advancement exam, I have a better idea of what the actual nomenclature for the instruction is. So for this one, it is Bumedinst Instruction 6010.13, also known as the Quality Assurance Program. I'm going to be going over a few of the bullet points. It's like a 40-page instruction from a lot of the times that I've studied. There's a lot of stuff in there that you can kind of gloss over. However, I do recommend reading every instruction at least once over for advancement. They change a little bit from cycle to cycle, but in general, not a lot changes. Like one drops off here, one drops off there. I'm pretty sure I've always seen this instruction all up for the HM1 exam. So the big bullet points right off the bat is yes, this is the QA program, the quality assurance. All fixed and non-fixed medical treatment facilities and dental treatment facilities must have one, which makes sense because if you're giving medical care, it's kind of important to make sure that it's quality. There is one ECOMS committee per privileging authority. Privileging authority basically means command. I don't think I've ever been somewhere where they had multiple privileging authorities, but I may be wrong. But generally, one hospital, one ECOMS committee. There's also a quality assurance committee that must be interdisciplinary. What that basically means is there needs to be different medical specialties on the committee. So, for example, you wouldn't want a committee full of dentists doing medical GMO type stuff, general medical officer stuff. Converse, you wouldn't want a bunch of GMOs doing all the dental stuff because they don't have a lot of direct experience in that area. So the goal is to get a bunch of people from as many disciplinaries as possible to be able to sit on the board and help do the QA stuff. So by responsibilities, I'm just going to go from the top down. So Chief of BUMED, their job is to interpret all the policies from above them, such as like DoD policy, SACNAV and policy, CNO policy, and provide guidance to all the medical facilities on what to do about it. They monitor the implementation of any medical and dental QA programs. They also provide consultation, educational support, and quality assurance info to all the Navy MTFs. There is an annual report that they have to do, and they also review all PCEs and malpractice data. So if Navy doctors are getting sued, kind of important for the big boss to know what's going on. Fleet commanders in chief, their job is pretty simple. They just need to make sure that their subordinates comply with the instruction. Type commanders, their job is to implement the TICOM-wide QA program, and they also visit their subordinate commands. The instruction does not specify how often they need to visit their subordinate commands, it just says they have to do it. OICs or COs, their job is to not only implement the QA program in their facility, but also have a written plan. So there needs to be a local instruction. How does your command specifically do QA stuff? They need to maintain Joint Commission accreditation. Please, it's Joint Commission, it's not JACO. Hasn't been JACO for a very long time. And also all PCEs, potentially compensatable, either way, PCEs must be reported and placed in a centralized database. I'll talk more about PCEs later because I see those a lot in like Blue Jacketeer and other study material. Then, not exactly in the chain of command, but the Naval School of Health Sciences in Bethesda also has a role in QA program, which, why them? If you think about the school that trains a lot of Navy doctors, kind of makes sense that they're the ones that do the educational workshops, and they also look at what education is needed, because incoming Navy docs should really be up to date on what the QA stuff is. So that's how the Navy School of Health Sciences fall into this. So they do 2 educational workshops each year, and they take a look at all QA educational stuff. Alright, and that is it for the main stakeholder part. Confidentiality, one thing that I thought was interesting when reading this instruction, it straight up says in it that QA stuff is exempt from the Freedom of Information Act. Reason being is the data is all pulled for QA purposes, like it's not trying to screw anyone over, it's just looking at how can we improve our care. So it's really not something that the public needs to know. That's really it for for that whole first 30 pages of the instruction. Up next we got some definitions. So these two I usually get mixed up and I have to reread them. Delinquency and deficiency. I recommend reading the instructions for all the other ones because these videos are more for me than for you guys, but if it helps you, cool. I normally have these so I can listen while I'm doing other stuff. So delinquency, that's basically only for MTF inpatient records. And that a delinquency happens if the medical chart isn't completed or the medical record isn't completed within 30 days of patient's discharge from the hospital. So because delinquency directly says it's only on inpatient, so small clinics that don't have inpatient wards can't have delinquent inpatient records. Deficiency is any variance from pre-established minimally acceptable standards of care. What that means is, are you operating within your scope of practice? If you are, if you messed up a procedure, what happened? Did that meet the minimum standard? What was going on? Nosocomial infection. Make sure you practice your aseptic technique. That's pretty much an inpatient acquired infection. So it's 72 or more hours after the patient gets admitted into the hospital. And the reason why it's 72 hours is any earlier than that they may have been infected before they got in the hospital. But about that 72-hour mark is where it's like, oh man, maybe something happened when they got admitted. All right, so the PCEs, the potentially compensable. Hey, good thing they don't look for spell or pronunciation in the advancement exam. PCEs basically mean lack of improvement, injury, or severity greater than ordinarily expected. So basically, they left your area worse off than they were before. The big thing about these ones are outcome measure type stuff, and compensable is right in the name. Can we get sued because of this? So there's 3 different brackets on PCEs. The first one is none or minor. So that's no delay in recovery, or there is a delayed recovery from anesthesia, but it doesn't impede the recovery. There's a misdiagnosis of a bone fracture, but no delay in recovery. So the big key there is, yeah, it may not have been great, but there wasn't a delay in their overall recovery. So none or minor. Next one is temporary. So yeah, they may have gotten jacked up a little bit, but they're going to be all right. The definitions in the book for this one are any falls with laceration or fracture. So make sure you get your bed rails up. There's a single post-op episode of sepsis, so they had some gross stuff going on, and they had antibiotics, and it was otherwise handled. Also, a delayed union of a fracture, so they didn't get splinted up as quick as they could have. And then incisional hernia and fracture of a tooth during anesthesia. For those last 2, I don't really know what those mean, but I don't need to. Temporary, jacks them up a little bit, but not going to cause long-term debilitating issues. The third one is long-term or permanent, which is just as bad as it sounds. So neurological injury after a fall, yeah, if they bump their head hard enough, it causes permanent damage. That's probably going to get sued because of that. If they came in with like a break or a tear, something to that effect, there's some loss of motion after the healing. So yeah, if their wrist gets splinted up and it doesn't heal right, that may cause some problem. Retention of a foreign body, basically, did you leave a scalpel or something in this dude, as well as loss of life. If someone dies, that generally is not good. I mean, of course, people die. But if an investigation happens and it's like, oh, there's something we could have done to prevent that, yep, there may be something to look at later. That's really it for BUMED Instruction 6010.13. I think the biggest, most important part of this is what are the stakeholders, what do they do, what are the definitions. There's a few more in there. I recommend giving at least that page a read. But again, gloss over the instructions, see if there's anything else. If there's anything you think I missed, I would love to see your comment, and maybe I'll do a reshoot of the video or just add a comment saying, yep, listen to this person. As well as any future HM1s. If there's anything that you've seen that I didn't cover from this instruction, please let me know.